Hello, hello all, welcome to this video on atrial fibrillation. So in the previous video, what we learned about the pathophysiology of atrial fibrillation, the clinical features and the ECG findings, also risk factors. Now imagine you palpated a pulse of a patient who had risk factors. Maybe the patient was elderly, was diabetic, hypertensive. You palpated his pulse and you got irregular pulse. Now you got ECG done of the patient. In ECG, what did you find? There were irregular RR intervals with absent P waves and presence of F waves. Now you know that this patient has atrial fibrillation. So now how do you proceed with this patient? Treatment of atrial fibrillation has mainly three things. Okay. So the first thing what happens is, I told you, there is no effective contraction of the atria. The atria is not properly emptying blood into the ventricles. Come to this image on the left side of the screen. So here, can you find this? Here, this is the left atrial appendage. Left atrial appendage. What happens, because the atria is not contracting properly, there are chances that the blood remains stagnant in this atrial appendage. Now when the blood is stagnant for a long time, what happens? There can be thrombus. Now this thrombus can enter into systemic circulation and then it can enter into cerebral arteries leading to thromboembolism. One of the important things that you should treat in a patient with atrial fibrillation is to reduce the risk of thromboembolism. Apart from that, you should also control the rate and rhythm. Then you should also reduce risk factors of atrial fibrillation. These are the three important things. Now let's start with scenario 1. Again, the patient has atrial fibrillation. You want to know from ECG. Now, in first scenario, the patient is unstable. You measured the patient's BP. The BP was very low. Okay. The patient had hemodynamic compromise. Or the patient has pulmonary edema. Or the patient has coronary ischemia. Coronary ischemia. Now, if the patient is unstable, directly go for cardioversion. It can be pharmacological, okay, or it can be electrical cardioversion. In pharmacological, you mainly use this ibutylide. In electrical, you will do QRS synchronized cardioversion. QRS synchronized cardioversion. Ibutylide is class 3 antiarrhythmics, and if you don't give it if there are features of increased QT interval. So is this clear? In next scenario, the patient is stable. His BP is all stable. There is no pulmonary edema. There is no coronary ischemia. In this thing, you will concentrate on all the above 3 points. So reduce the risk of thromboembolism, control the patient's rate, rhythm, and reduce the risk factors for atrial fibrillation. This is the first scenario. Now, in second scenario, you will see the duration. Since how long the patient has atrial fibrillation. This is very important scenario. Okay, the risk of developing thrombus increases after 48 hours. Like the patient is likely to have thrombus in the left atrial appendage if the duration of atrial fibrillation is more than 48 hours. If it's less than 48 hours, the risk is slightly lower. So in second, the patient has atrial fibrillation for less than 48 hours. And also there is no history of prior embolism. The patient does not have prior thromboembolic events. No prior embolism. Then there is no hypertrophic obstructive cardiomyopathy. And there is no rheumatic mitral stenosis. Rheumatic MS. Okay, in this scenario, you definitely know that the patient developed atrial fibrillation within less than 48 hours. Along with that, the patient does not have any prior history of embolism. There is no hypertrophic cardiomyopathy and there is no rheumatic mitral stenosis. In this case, you can directly do cardioversion. However, if the duration is more than 48 hours, it means that the thrombus has already formed. If you do cardioversion in this patient, you might itself cause what? Embolic events in the patient. Therefore, what will you do? Okay, the duration is either more than 48 hours or you do not know since when the patient is having AF. Okay. Or the patient has these three risk factors, like there is prior embolism or there is hypertrophic cardiomyopathy or there is rheumatic MS. In this condition, you have two options. So you can do 3 weeks of anticoagulation. Start the patient on anticoagulation. Then do cardioversion. After that, after cardioversion also, after 4 weeks, you will continue. You will continue anticoagulation. So this is one option you have. The second option is directly perform investigation. So look for thrombus. You can perform transesophageal echocardiography or you can perform cardiac CT. So first will always be start anticoagulation. Now once you start the patient on anticoagulation, perform transesophageal echocardiography and or cardiac CT. Now in this imaging, if there was no thrombus, no left atrial thrombus, then you can directly do cardioversion. And following cardioversion, you will still give 4 weeks of anticoagulation. Now, why do you give 4 weeks of anticoagulation even after cardioversion? Because even after cardioversion also there is risk of formation of thrombus. So to prevent that, 4 weeks of anticoagulation is done. So is this clear? This is the important scenario. If the duration is less than 48 hours or if the duration is more than 48 hours or unknown or the patient has risk. If the duration is less than 48 hours and there is no history of prior embolism or no HCM or no rheumatic, you can directly do cardioversion. However, if the duration is more than 48 hours, the chances of forming thrombus is very, very high. Okay, therefore, there you have two options. You can start with anticoagulation, continue it for 3 weeks, then do cardioversion, okay, and following cardioversion, continue anticoagulation for 4 weeks. Okay. Now, if you want to shorten this course, what you can do, you can directly start anticoagulation. Starting anticoagulation is must. Then after starting anticoagulation, you will either perform transesophageal echocardiography or you will perform cardiac CT and you will see if there is thrombus or not. If there is no thrombus in left atrial appendage, you can do cardioversion and after cardioversion, you can continue 4 weeks of anticoagulation. This is very, very important. Now, this was what I discussed was acute treatment of atrial fibrillation. Now, after if atrial fibrillation acute treatment is done, what is the long-term treatment? So the important thing still remains is you will have to prevent stroke. Okay. How do you assess? Like you give 4 weeks of anticoagulant. After 4 weeks of anticoagulation, you have to still decide, like, should you stop anticoagulation or should you continue the patient on anticoagulation. This is assessed with the help of CHA2DS2 vascular score. Now everything is done. Okay, you treated the patient, you did, like, you performed TEE, you the thrombus was not there, so you gave cardioversion. 4 weeks of anticoagulation is done. Now you have to decide after 4 weeks should you continue or not. For that, calculate this score of the CHA2DS2 vascular score of the patient. Now let's see what this score is. Okay, remember there is CHA2 and S2. So this score has scoring. If these risk factors are present, then the score is 2. For others, it's all 1. Okay. So C is congestive heart failure or LV dysfunction. H is hypertension. A2 is age more than 75. D is for diabetes mellitus. S is prior history of stroke or TIA or thromboembolism. V is for vascular disease. A is for age 65 to 74. Remember, age if more than 75, the score is 2. Age, if the age is between 65 to 74, then A score is 1. Then sex category, if the sex is female. So you will allot 1 or 2 points for each risk factors. Okay. Now, if the score is more than 1, you will start the patient on anticoagulation. Is this clear? But what is a major side effect of anticoagulation? The risk of bleeding, right? When you start patient on anticoagulation, there are certain patients who might have bleeding, right? Like, you try to control one thing and you end up adding another condition to the patient, which is also very, very risky. So for that, you will also assess bleeding risk of the patient. Now, if you start the patient of anticoagulant, what is the risk that the patient might have bleeding adverse effects? For that, you will have to use Has-Bled score. Okay. So if the patient has hypertension, give 1 point. If the patient has abnormal liver or renal, then give 1 point for each. For example, if the patient has both abnormal LFT, impaired RFT, then it will be 1 plus 1, which is 2. If the patient has history of stroke, give 1. Bleeding, then under 1 score. Labal INR 1. Elderly, age more than 65, it's 1. Any history of drug or alcohol, then 1 point each. If the patient has both, you will be giving 2 points. Okay. And you will start the anticoagulation if the risk of stroke is higher than risk of bleeding. Is this clear? First, assess CHA2DS2 VASc score and also assess Has-Bled score. If the risk of developing stroke is higher than risk of bleeding, then start the patient on anticoagulant. Now, which are the anticoagulants that you can use? So you can start the patient on factor 10A inhibitors. So factor 10A, remember 10A has XA in it. Apixaban, rivaroxaban, edoxaban. They are factor 10A inhibitors and they have XA in their names. Then you can also give the patient antithrombin inhibitor. Can you tell me which is the antithrombin inhibitor? It is dabigatran. Okay. And oral vitamin K antagonist, which is it? Warfarin. This is given especially if the patient has rheumatic MS. Or if the patient has mechanical valves. Okay. Just remember all this. For the final year, the score is important. Assess the CHA2DS2-VASc score. And if the score is more than 1 and the risk of bleeding is less, you'll start the patient on factor 10A inhibitors, apixaban, rivaroxaban, edoxaban. or dabigatran. If the patient has rheumatic mitral stenosis or mechanical valves, you can start the patient on warfarin. So this is how you reduce the risk of stroke. What were the other two? You will control the rate and rhythm, and you will reduce the risk factors for atrial fibrillation. So let's come to the second one, rate control. It has to be done in all the patients. What is the rate? What is the rate in atrial fibrillation? I told you it's between 100 to 160, right? So now you have to control the rate. Ideal rate is, so resting, the patient should have less than 80 beats per minute. Okay. And during exercise, it should be less than 100. Ideally they say less than 100, but it's very difficult to control less than 100. So you can take it as 100 to 110 beats per minute during exercise. There are two important things that you can use. So important things are beta blockers are used and calcium channel blockers. In calcium channel blockers, it is verapamil and diltiazem. In beta blockers, what is used? Bisoprolol. Remember, beta blockers are drug of choice, especially if the patient has increased cardiovascular risk. So bisoprolol. If the patient has heart failure, then you can use digoxin. So in patients with heart failure, you can use digoxin. Remember these three things. Ideal range is 80 during resting, 100 to 110 during exercise, and you can use three. One is beta blocker, calcium channel blocker, and digoxin. Okay. Second is rhythm control. So you control rate of the patient despite controlling rate. The patient is still symptomatic, or you are not able to control rate. Then you should always concentrate on rhythm. So for rhythm, you can use multiple drugs, okay? You can use beta blockers, which we already discussed, okay? You can use calcium channel blockers, same. They are diltiazem and verapamil. Diltiazem, verapamil. Then you can use class 3 antiarrhythmics, which are class 1 antiarrhythmics. They are sodium blockers. Which are they? Do you remember? 1A is disopyramide. Then you can use 1C. Flecainide and propafenone. One of the important things that you should remember in this is it can be used in patients without any structural heart disease. Without any structural heart disease. Then third that you can use is class 3 antiarrhythmics. They are sotalol and dofetilide. In this video itself, we had discussed about another class 3 antiarrhythmics. Do you remember it? If the patient is unstable, you can give pharmacological or electrical cardioversion. Which was the pharmacological that you used? Ibutilide. So ibutilide is also class 3 antiarrhythmic, and sotalol dofetilide is also class 3. Sotalol along with class 3, it also has other effects as well. Okay. One of the important class 3 is it can cause QT prolongation. Adverse effect, okay? You should remember this. Then you can use dronidiron, but it should not be used cannot be used. Another option used if the patient has AF with heart failure or persistent AF. Or AF. Now don't remember, just remember name, dronidiron. Okay. Amiodaron, this is very, very, very important. Okay. Now you can use which were the first two? Beta blockers, calcium channel blockers, you can use class 1 antiarrhythmics, you can also use class 3 antiarrhythmics, and other option was dronedarone. Then you can also use amiodarone. Amiodarone is a broad spectrum antiarrhythmic, I can say. It can be used in heart failure, coronary artery disease, used in heart failure, coronary artery diseased patients. Now, important thing is adverse effects. There are multiple adverse effects of amiodarone. I'll be telling it separately. For example, it can have pigmentation, it can have corneal microdeposits, idiopathic pulmonary fibrosis, hypo or hyperthyroidism. Because of the adverse effects, the long-term use of amiodarone is very, very difficult. The next option is catheter and surgery. So you first gave the patient cardioversion. Then with the cardioversion it was not stabilizing, so you started the patient on antiarrhythmic drugs. Even with that, if it's not controlled, then the option that you have is catheter and surgical ablation. This is the treatment. And third part was you to reduce the risk factors for atrial fibrillation. What were the risk factors we discussed in first video? Age, presence of hypertension, diabetes, obesity, all like sleep apnea, they were right? So control hypertension, control diabetes of the patient, whichever is modifiable risk factor, try to control those risk factors. So this is about it. I will quickly recap. The main aim is to reduce the risk of thromboembolism, to reduce the patient's symptoms by controlling rate and rhythm, and reduce the risk factors of atrial fibrillation. Formation of thrombus is very, very important. You should see if the thrombus has formed or not. If the patient is unstable, directly go for cardioversion. If the patient is stable, look all the three factors, treat all the three factors. In second scenario, if the duration is less than 48 hours or more than 48 hours, less than 48 hours, there are no risk factors, then directly go for cardioversion. If the duration is more than 48 hours or unknown, then you will always start the patient on anticoagulation, then do cardioversion, then continue anticoagulation for 4 weeks. Or you can start anticoagulation, perform transesophageal echocardiography or cardiac CT. If there is no thrombus, continue, give cardioversion and continue anticoagulation for 4 weeks. In stroke prevention, important thing is CHA2DS2-VASc score. If the score is more than 1, start the patient on anticoagulants. Rate control, you can use 3 beta blockers, calcium channel blockers or digoxin. Rhythm control, along with these you can also use class 1 and class 3 antiarrhythmics. Apart from that, also remember amiodarone and dronedarone. Amiodarone is a broad spectrum, however it has lots of side effects. For chronic use, the use is limited. If there is no improvement with cardioversion and antiarrhythmic drugs, go for catheter and surgical ablation. Then mitigate risk factors for atrial fibrillation. So this is in brief about treatment of atrial fibrillation. I hope this is very, very clear. Okay. And thanks a lot. Bye.